I'd like to begin with a rather unfortunate case. This patient had surgery for spinal stenosis about 2 years ago. He's a 64-year-old man who was doing well after the surgery, but 2 years later, the pain came back. When he returned to the hospital where he had the surgery, they told him that his 5th and 6th vertebrae had slipped and needed to be corrected. In other words, he was diagnosed with spondylolisthesis and was told he needed screw fixation. They recommended spinal fusion surgery since the bones had shifted. Now, did this condition develop because of a mistake the doctor made? No, that's not the case. There are 2 main causes of spinal stenosis. One is that the ligaments thicken and press on the nerves. The other is spinal instability, where the spine moves or wobbles more than it should. If there had been significant spinal instability back then, the doctor would definitely have performed a stabilizing procedure. For example, ligament reconstruction or screw fixation to treat the unstable spine at its root. But 2 years ago, there was only stenosis. The spine wasn't unstable. Because there was no instability, only nerve decompression was performed. When you're decompressing just the nerves, it might seem like you can simply remove the thickened ligaments. But in reality, when using a microscope or endoscope, it's hard to cut just the ligament precisely. So part of the lamina is usually removed, and nearly half of the facet joint is shaved down as well. Still, it's considered a minimally invasive surgery. About 75% of patients do well and live without major problems after this type of procedure. But in about 25% of cases, like this 64-year-old man, spinal instability worsens, and the vertebrae slip forward. That becomes spondylolisthesis. So how should reoperation be approached in such cases? If you simply decompress the nerves again, the problem can come back in 1 or 2 years. In these situations, stabilization through ligament reconstruction is necessary. By reconstructing the ligaments in the decompressed area and doing additional decompression, so the bones don't keep slipping or shifting, most patients improve. There's also something called a dynamic view X-ray, which is taken while bending or extending the lower back. If that X-ray shows the bones slipping back and forth too much, a minimally invasive anterior spinal fusion might be needed. In that case, the displaced bones are realigned through the abdomen, and screws are inserted from the back through the skin to stabilize everything without major bleeding. Today, I've explained how 25% of patients who undergo small procedures, like endoscopic or microscopic decompression for spinal stenosis, may experience a recurrence of pain. However, if detected early, the underlying cause can be treated through ligament reconstruction. Thank you.